John, I think you've worked with acalabrutinib a fair amount. What you want to walk us through that a little bit?
Yeah, so both agents that are approved are ibrutinib, acalabrutinib for CLL. Those are both covalent inhibitors, which means they form an irreversible bond to BTK, to the activation site of BTK. So they have similarities in terms of their mechanism, how they bind to BTK, how they inhibit BTK. But what you already said is that acalabrutinib, the second generation molecule, which is next in line now and which is approved and is probably going to be used more frequently in the time to come, it is more selective for BTK and doesn't have these off-target effects. With that, we could say, well, maybe it has advantages in terms of side effects. Cross-trial comparisons are difficult, and therefore I don't think we can definitively conclude that the newer generation molecules are clearly better in terms of certain side effects. I think we need to wait for the randomized studies which are ongoing, comparing acalabrutinib with ibrutinib to make a definitive conclusion about, for example, cardiac side effects. So mechanism of action is to some extent similar, but the newer generation molecules are more selective. The other distinction is that ibrutinib is given once a day. The second generation molecules are given twice a day. I think that's based on the idea that if you give it twice a day, maybe you have a little better occupancy of the target round the clock. But I think we already have a feeling that the efficacy of the molecules is very similar. So maybe that has some benefit. In terms of side effects, in terms of efficacy, at least that's my read of the data. I think the molecules are very similar. If you treat a CLL population, you can expect that the vast majority of patients are gonna respond. Or do you have a different take on that? I think the differentiation is most likely going to come from the side effects, not so much from the efficacy.
I agree completely with you. I think that it's very hard to I mean, I think most people think that they're going to work pretty well, pretty equally. There are large randomized trials going on. We wait for those results, but I think they're really going to be, where there may be distinctions is in the side effect profile. And you brought up some of the differences. Perhaps it's a little bit more, acalabrutinib may be a little bit more specific, but it is given twice a day versus once a day. And the thing that comes up, at least here in Tennessee, a fair amount in our patient population, is that there is patients can't be on a proton pump inhibitor. They can't be on a protonics, and that's a lot of my patients. That you need the acidic environment of the stomach in order for the drug to be absorbed, and so it's not necessarily obvious to me that you should all patients should be on one or all should be on another. Perhaps they're useful in different settings.